This is Jessica Templer from the Epilepsy Division in the Department of Neurology at Northwestern University Feinberg School of Medicine. This presentation is an overview of the chapter written on the diagnosis and classification of seizures and epilepsy. In this PowerPoint, I will initially review definitions and terminology. This will be followed by a review of the approach to a new onset seizure, followed by highlighting relevant questions related to the history and physical exam to discern whether the event was a seizure. Then I will discuss how to determine whether the seizure was provoked and whether the patient has epilepsy. This will include a discussion of initial investigations. I will then discuss principles of both seizure and epilepsy classifications. Listed here are definitions and terminology used throughout the chapter and the PowerPoint. Acute symptomatic seizure is a seizure which occurs within 7 days of a precipitating symptomatic insult, although the time frame may be extended if the underlying insult has not completely resolved. A remote symptomatic seizure is a seizure that occurs at least 7 days after a neurologic insult in the context of a brain lesion. A provoked seizure is a seizure in the context of a provoking factor. For example, certain medications, drug withdrawal, alcohol withdrawal, illicit drugs, or metabolic abnormalities. An unprovoked seizure is a seizure which occurs in the absence of the aforementioned triggers. Epilepsy syndrome, it describes a group of epilepsy presenting with a cluster of electroclinical characteristics. This is a case highlighting the importance of asking the appropriate questions and putting the clinical exam in context. This is the initial ED assessment by the first physician. 33-year-old male who reports he was suddenly awakened with severe mid-back pain, sharp in nature, not really short of breath, no abdominal pain, no vomiting, no diarrhea, no black or bloody stools, no urinary symptoms. He arrives with normal vital signs and 100% pulse ox, but looks pale and has petechiae around his eyes and his upper chest. No history of heart problems, no drugs, no alcohol, no trauma. ED findings were the labs and CT images were reviewed, a liver hemangioma, and age-indeterminate end-plate compression deformities of the T6, T7, and T8 vertebrae. In his summary, it's a 33-year-old male denying recent trauma with upper back pain and facial bruising and lacerations. Recommended a tox eval. CT head and face to rule out fractures, as history is inconsistent with the clinical exam MRI spine. So as you can glean from the summary, the physician clearly doesn't believe what the patient is saying and suspects that there was some trauma that actually caused his symptoms, of which the patient is not admitting. Upon further questioning, a second physician provides a history, assessment, and plan outlined here. 33-year-old man who presents to the ED with complaints of severe upper back pain that woke him up from sleep. Does not recall any traumatic incident or injury. Notes that when he woke up, his bedside lamp was knocked over and the lampshade was smashed. Also notes that there was blood around the bed and his mouth where he noticed a swollen lip and tongue on the left side. States he smoked marijuana last night, denies chest pain, shortness of breath, numbness, tingling, weakness, no loss of bowel or bladder control, denies abdominal pain. In the imaging reviewed, it's acute compression fractures of T6, T7, T8, and T9, and ultimately the impression is a likely generalized convulsion, which warrants further evaluation with MRI, brain, and EEG. Herein lies the importance of asking the correct questions and assessing a patient with a consideration of a convulsion as the cause for his presentation. Here is another case study highlighting the importance of asking the right questions. This is a 36-year-old right-handed male with no significant medical history who presents with a witnessed generalized convulsion. No known prior history of seizures. CT of the head was concerning for a mass lesion, and the MRI is displayed here. Imaging findings led to a neurosurgical consultation. On further questioning for 18 months, the patient had been having episodes of, quote, panic attacks, for which it was recommended that he see a therapist. His episodes or panic attacks consisted of a noxious smell associated with an abnormal metallic taste, intermittently progressing to difficulty processing what was happening around him. And at times they would progress to a sensation of panic, chest tightness, shortness of breath, or diaphoresis. Here is the image in the coronal cut, and at the most anterior aspect of the flare abnormality, it's clear that the hippocampus is not involved. However, the lesion does involve the insula. One of the most common symptoms of seizures involving the insula, amygdala, frontalopercular region is an olfactory aura. The noxious smell is often associated with a gustatory aura or a metallic taste, which is what this patient experienced. The propagation of the seizure leads to symptoms of difficulty with processing, chest tightness, and panic. If no further questions were asked, the patient himself would not have thought of his diagnosed, quote, panic attacks as being related to this newly discovered lesion. Only with asking the right questions to obtain this history were we able to provide the patient with a clear explanation regarding his recent events and the relationship to the glioma identified after his first convulsion. After being diagnosed with seizures, in addition to a likely low-grade glioma, the patient was actually reassured, as he thought he was going crazy and was psychiatrically unwell. He was since started on levetiracetam 1,000 milligrams BID, and his seizures have stopped. In this chapter, we present an algorithm to approach a patient with a possible new onset seizure. I've highlighted the importance of asking the right questions to ensure that this is a first-time seizure, and in addition, it is of utmost importance to confirm that the event itself was a seizure and to exclude other possible diagnoses. A comprehensive list is provided in the chapter, but the most common differential diagnoses include migraine, TIA, and syncope. As you can see here, the algorithm begins with an individual with a possible new onset seizure, and the first question asked is the event description and witness report suggestive of a seizure? If the answer is no, evaluate other diagnoses. If yes, obtain a history and perform a physical exam. So in the clinical history, there are essential questions of which must be asked. However, I have discussed some of these, and this is not an extensive list, including all questions that should be considered, but these are key questions that must be asked. If the patient does not recall the event, it is essential that someone contacts a witness. The report that the objective description can provide can really help guide the differential. Key questions for both the patient and a witness: symptoms at the onset of the event, both subjective and objective, duration of the event, the subjective experience of the event, including the time to return to baseline. It is very common that when a patient says they woke up confused on the floor after they maybe passed out and no description is provided, that will be labeled as postictal confusion. However, it's solely syncope and they're just asking what had happened. However, when the patient is already, the next thing that they remember is being in the ER, then a seizure really must be considered. Again, asking the description of the event, the symptoms at the end of the event, and always doing a complete thorough physical exam, looking for tongue bite, as I mentioned in the prior case, self-injury, incontinence, skin exam, identifying signs of trauma in addition to evidence of a neurocutaneous syndrome, cardiac neurologic exam. And so going back to the differentials, again, these are further discussed in the chapter, but to highlight a few, there are distinct components that really tend to lead you in one direction in terms of considering the differentials. With syncope, the typical prodrome is lightheadedness, tunnel vision, provoking factors. The duration of the event is typically very brief, less than 15 seconds. Movements during the event, it's important. A lot of times people will talk about convulsive syncope as a quote-unquote convulsion when in fact they passed out, had loss of consciousness related to a syncope, and had a few jerks, which can solely be related to syncope itself and is not a convulsion. The time to recovery, as I mentioned previously, is rapid. TIA, most commonly patients can report the entire event. It's a rapid onset of negative symptoms, weakness, numbness, aphasia. The duration of the event is key with TIA. Most commonly, it's going to be greater than 5 minutes. There's no associated abnormal movements and no associated loss of awareness. Now, when considering migraine, the duration of the visual aura is key. A visual aura for an occipital seizure may be colored lights or colored shapes and symbols, which can sound very similar to a visual aura, to an aura associated with a migraine. However, the duration of the visual aura with a migraine is commonly greater than 5 minutes. They'll often describe a headache as unilateral, pulsating. There may be a progression of neurologic symptoms, which is prolonged compared to with a seizure. The duration of an event in total may last longer than 24 hours. There are no loss of awareness, no abnormal movements, and family history of migraines is also to be considered. Psychogenic non-epileptic events. There is a history of physical, emotional, or sexual trauma. However, patients with epilepsy may have this history as well, so it's important to identify that, but also consider the description of the event before making the diagnosis of a psychogenic non-epileptic event. Duration of events can last greater than 2 minutes. The symptoms wax and wane in their intensity. Eyes are closed. Clinical features can be pelvic thrusting, vocal stuttering, asymmetric shaking limbs, and behaviors that can be modifiable by the examiner. Now, determining whether the seizure was provoked, there are factors that should suggest that an urgent evaluation is necessary or a non-urgent evaluation. Is there evidence of fever, focal deficit, or mental status change as outlined in this algorithm? If the answer is yes, there must be an urgent evaluation for an acute symptomatic seizure. Laboratory testing, urgent CT and or MRI, I often suggest an MRI, urgent EEG or considering continuous EEG. And then the patient is often admitted for an inpatient admission in order to complete the workup and do a thorough investigation. If there is no evidence of fever, focal deficit, or mental status change, the next question to consider is whether the seizure was provoked. Common provoking factors which should be considered in a patient with a first-time seizure include the following: sleep deprivation, alcohol use, medication use, with the most common triggers being tramadol, certain antibiotics, bupropion, withdrawal, most common benzodiazepines or barbiturates, drugs, with the most common being cocaine, amphetamines, ecstasy, opiates, or metabolic causes, including hypoglycemia, hyperglycemia, and hyponatremia. Keep in mind that these factors often provoke seizures in patients with underlying epilepsy as well, for example, in the case of sleep deprivation or alcohol use, and this should be considered. If any of these factors are present, a non-urgent evaluation is appropriate, including laboratory testing, CT, although often an MRI should be considered, an outpatient EEG, discussing lifestyle modifications to address possible provoking factors. The use of an anti-epileptic medication can be deferred at that time. So moving forward, when we think about the patient who presents with a first-time seizure, or perhaps as presented in the case earlier, has been having seizures for a year, 18 months, perhaps solely in aura, it is very helpful to think about where the location of a lesion is and the questions that should be asked regarding seizure semiology. This is, as presented in the chapter, is a guide, but something to consider. And really, it's a matter of thinking about the functional anatomy in the cortex that's involved. But that being said, all potential symptoms of a seizure should be asked, given that seizure spread may cause symptoms in a location distant to the lesion itself. So frontal lobe lesions most commonly present, as I discussed earlier, olfactory, autonomic, in addition to motor seizures. Motor seizures may be simple motor, tonic, clonic, myoclonic, asymmetric, tonic, versive, hypermotor. I always ask patients if they sleep alone and if they share a bed with someone, because they can be having hypermotor seizures out of sleep. And given the nocturnal predilection for seizures in frontal lobe lesions, it would be of utmost importance to know whether someone has been in bed with them to witness an event, and if so, to ask the partner about those events. In addition, patients may present with automatisms or gelastic seizures. In addition, they can have non-motor seizures, which include dyscognitive, aphasia, dysphagia, apractic, or dialeptic seizures. Regarding temporal lobe seizures, the most common auras are an abdominal aura, which can be described as a rising epigastric sensation. Often they will describe the sensation as if you've dropped on a roller coaster. Can be associated with fear. Olfactory aura, this is often a noxious smell that's bothersome but difficult to label as to exactly what it is. A gustatory aura, often a metallic taste. Auditory aura, abrupt ringing, buzzing, chirping, voices, etc. Psychic, with memory illusions, deja vu, jamais vu, hallucinations, visual illusions. Autonomic, with heart racing. You can have automotor seizures, dyscognitive, dialeptic, aphasic seizures, in addition to apneic seizures or tachycardia, bradycardia, and sometimes asystole. As such, these questions must also be asked when you see that the temporal lobe is involved with any lesion. To pause for another case highlighting the importance of considering the anatomical location in seizure semiology, here is a case of a 21-year-old woman who presented with a first-time convulsion. As you can see, a ring-enhancing lesion is seen with surrounding T2 flare hyperintensity. Now, when we think about the anatomic location, this lesion is sitting right in the right temporal operculum. And when we think about the functional anatomy of this area, specifically this is near Heschel's gyrus. And upon further questioning of this patient, 5 days prior to her convulsion, she started hearing sounds that were present in her left ear and the contralateral ear. She described sounds as alternating between muffled voices, buzzing, and songs. Initially occurred lasting a few minutes, every 20 to 30 minutes, and over time increased in frequency, occurring frequently throughout the day. At her postoperative visit, I reiterated the importance of notifying us if the auditory symptoms recurred, as these were seizures and may signify that she is at risk for a convulsion. While I consistently ask patients if they have ever heard sounds that weren't present, for this patient in particular, it was a question that was relevant given the location of her lesion. In terms of insular epilepsy in the context of a lesion, patients may present with variable seizure semiology. These include somatosensory auras, which may be described as paresthesias with tingling, warmth, a tension feeling, electrical pain sensation. Sometimes they can describe these symptoms in large areas. They can be bilateral. There's no Jacksonian spread. Sometimes they'll describe a sensation of constriction or a feeling of suffocation or choking. Sometimes they can have different symptoms coming together with olfactory, gustatory, these viscerosensory symptoms, auditory symptoms. They may describe a psychic aura like anxiety, panic, or fear. They may describe dyspnea or breathlessness, in addition to episodes of hypersalivation, dyscognitive dialeptic seizures, or a speech apraxia or automatisms. When the parietal lobe is involved, patients may also describe somatosensory auras, although often this is more localized in the area involved. Again, tingling, numbness, pain, thermal sensation. They may notice disturbances of body images. They may notice a sensation of movement of a part of the body, complex visual hallucinations. They may have tonic motor seizures, focal motor, automatisms, head deviation with postictal TODs and postictal dysphagia, and this is often a phenomenon of seizure spread. Regarding occipital lesions, the aura is a visual aura often consisting of an elementary visual hallucination, such as colored shapes. Sometimes it will be a colored shape moving in position, changing in size, can be flashing colors. Sometimes people will describe ictoblindness. In addition, they can have uncontrollable eye movements, the sensation of eye pulling, nystagmus, contralateral head and eye deviation, focal motor seizures, or automatisms that are again often a reflection of spread. Now, returning to our algorithm, once a patient is considered to have a probable unprovoked seizure, next steps include reviewing the relevant clinical history to ensure the patient has not had unreported auras or focal seizures, obtaining an EEG, and an epilepsy protocol MRI. Now I will provide a summary of the principles of seizure classification, which are discussed more extensively in the chapter. This is a case of a 35-year-old right-handed female with right temporal lobe epilepsy and depression. At onset at 33 years old, her seizures consisted of nausea, epigastric rising sensation, and heart palpitations, which could intermittently progress to loss of awareness. Witnesses would describe observing lip smacking, which could progress to a generalized convulsion with head version to the left. And here in this image, you can see a T2 flare hyperintensity in the right mesial temporal region with subtle expansion of the right amygdala, and this case also highlights the importance of obtaining an epilepsy protocol MRI. This lesion raises the concern for focal cortical dysplasia or possibly a low-grade glioma. Here's an example of her EEG. For those who aren't familiar with EEG, here we're looking at the left temporal chain above the right temporal chain, followed by the left parasagittal chain, followed by the right parasagittal chain. And here you can see that there is an evolution over the course of these 10 seconds that are displayed. There's a rhythmic theta activity that's evolving in the right temporal chain, and this correlates with her ictal symptoms. When we categorize this patient's seizure semiology, it is best to use standard terminology to ensure we are all using the same language. That being said, there is ongoing discussion about approaches to seizure and epilepsy classification. On a basic level, seizure semiology can be divided into subjective symptoms, which is called an aura, and objective signs or symptoms. While auras and seizures are often thought of as distinct entities, both are the consequence of synchronous hyperactive neuronal activity. There's essentially no physiologic distinction between the two. It is the location of the ictal activity that determines the patient experience. Armed with an understanding of seizure semiology, especially in the context of a lesion, the appropriate questions will be asked. Our standard semiologic seizure classification can be seen here and is presented in the chapter. Returning to our case using the semiologic seizure classification, again, this is a 35-year-old right-handed female with right temporal lobe epilepsy and depression. She described a sensation of nausea, epigastric rising, and heart palpitations, which can intermittently progress to loss of awareness. This is summarized in our semiologic seizure classification as an abdominal aura, which then progresses to an autonomic seizure. The reason this is called an autonomic seizure is when this was observed in the EMU, we recorded that on a single lead EKG, she had notable tachycardia. If we had not confirmed that in the EMU setting, this would be labeled as an autonomic aura. In her seizure, witnesses describe observing lip smacking, which may progress to head version to the left and a generalized convulsion. And this is summarized as an automotor seizure, which then progresses to aversive seizure with head to the left and a tonic-clonic seizure. In addition to seizure classification in the chapter, we also discuss the principles of epilepsy classification. Felix Rosenau presented a new integrated epilepsy classification scheme, which is highlighted here. This approach integrates seizure semiology with the ILAE classification. The ILAE is the International League Against Epilepsy, which has created a classification system recently updated in 2017. The integrated epilepsy classification scheme merges the two classification systems together, bringing seizure semiology with etiology, seizure type, and epilepsy type together, allowing for a comprehensive summary of a patient's epilepsy while also providing standardized language which will be useful for research moving forward. In summary, in the headline, or epilepsy core is the localization, whether it's focal, generalized, or unknown, including the etiology. Seizure type, which includes the semiological seizure classification similar to what I've described before. The epilepsy type, which is focal, generalized, or unknown. And if the epilepsy is focal, it's important to provide a location of the epileptogenic zone as exact as possible or needed. And here you would add the epilepsy syndrome in parentheses if available. The etiology is listed, including structural, genetic, infectious, metabolic, immune, or unknown, and any relevant comorbidities or relevant patient information will fall under comorbidities. In summary, using the integrated epilepsy classification scheme, our patient would be presented as follows. The headline would include right temporal lobe epilepsy secondary to suspected focal cortical dysplasia. The seizure type would be similar to what was presented earlier with an abdominal aura, autonomic seizure, which then progresses to an automotor seizure, versive seizure, and then progresses to a bilateral tonic-clonic seizure. The epilepsy type is a summary focal right temporal lobe epilepsy. Etiology would be structural, as we suspect likely focal cortical dysplasia, and relevant comorbidities would include depression. This PowerPoint has provided an overview of our chapter, Diagnosis and Classification of Seizures in Epilepsy. Thank you for your attention. Here are some suggested readings which are also included in the chapter as well.